Medical cannabis has become legal in several states, allowing clinicians to prescribe it. However, studies have demonstrated that prescribers may not be equipped with adequate knowledge to prescribe marijuana products. Even clinicians who are not prescribing still encounter patients who are using marijuana in various forms. Patients additionally have their own expectations, which may or may not be based in the science of cannabis. This seminar tonight will overview the pharmacology and therapeutics of cannabis products, as well as the impact the use of these products may have on the patient, such as drug testing results, employment, and driving. This lecture will also review legal limitations of state cannabis laws. And we're very fortunate this evening to have Dr. Randall Tackett. Dr. Tackett received his PhD in pharmacology and toxicology from the University of Georgia. After completion of a postdoctoral fellowship at the Medical University of South Carolina, he returned to the University of Georgia College of Pharmacy as an assistant professor. He is currently professor and associate department head in the Department of Clinical and Administrative Pharmacy and the Doctor of Clinical Trials Certificate Program in Regulatory Affairs. He also holds adjunct faculty appointments at Alliant University and Fairleigh Dickinson University. He has given numerous lectures about dealing with adverse drug interactions, cardiovascular disease, substance abuse, psychopharmacology, and forensic pharmacy. He is recognized as an expert in both pharmacology and toxicology in the area of substance abuse. And so it is with great pleasure that I turn this over to Dr. Tackett.
Thank you, Phil, and thank you, everybody, for joining us for this webinar. This has been an interesting journey with regard to marijuana. I remember when I was an early assistant professor and marijuana was being discussed about being legalized. I remember saying to myself, there is no way that marijuana will be legalized in my lifetime. And that just comes back to emphasize why you should never say never, because it does come back to get you. There has been a lot of issues that have come up. There's a lot of misperceptions we see with the public. There's a lot of people that think that legalization of medical marijuana equates to legalization of marijuana. And there is a lot of issues that are starting to arise. I've given several talks in different states, the medical associations, and one of the things is that the physicians and clinicians that are going to be prescribing this really are somewhat in a void with regard to what they can get. At some states, they've legalized marijuana, but they have not developed the dispensaries and things like that that is necessary to give it. So, for example, I told one state, your issue is you can prescribe it. The patient has nowhere to get it. And we've even had instances. I know here in Georgia, I had recently a legal case where a guy had a prescription and bought weed on the street, and he trying to convince the officers that he had a prescription and that he gave it to the dealer. And the dealer took his prescription and probably used it for something else. What we're going to try to do is we're going to talk about the cannabinoids in general. The other thing you're going to hear me talk about is there's a lot of concern, a lot of misinformation, a lot of partial information out because people talk about marijuana, they talk about CBD, other cannabinoids, and so we're gonna sort of touch on those. I've used this slide since I've been teaching about marijuana for years. And I sort of like the slide because it sort of represents one of the things that I have seen. Carlini basically made a statement. Very few drugs, if any, have such a tangled history as a medicine. In fact, prejudice, superstition, emotionalism, and even ideology have managed to lead cannabis to ups and downs concerning both its therapeutic properties and its toxicological and dependence-inducing effects. And that, in fact, is one of the big issues. One thing that's happened is people have their agendas for pushing marijuana. A lot of people have felt like if we get medical marijuana legalized, that opens the door for recreational. I've had students and healthcare professionals that think that marijuana is legal to use recreationally because it's been legalized. And we have things that the public believes. For example, a lot of people say marijuana is safer than alcohol because with marijuana, you know just how high you are, whereas with alcohol, you don't. A lot of people do not think you can get addicted to marijuana. So there is a lot of misinformation out there, and there's a lot of information that's coming out on the internet and through various social media, which really is just misinformation. One of the things when I'm dealing usually with either a legal case or a student issue or something like that, I usually try to find out, well, where did you get this information? And it just comes from a number of sources, and AI is adding to it. We're going to talk about just in general marijuana, both from a recreational and medical standpoint, but focusing a little bit stronger on the medical. So, when we talk about medical marijuana, one thing that comes into play is that we have to differentiate between recreational and medical. There is the belief that legalization handles both of them, and that's not true. We also have the issue that a person, if they've got a prescription for medical marijuana, they can just get it from somewhere off the street. We now have the gummies, the edibles, which have opened a new door. A lot of states that are trying to legalize medical marijuana are addressing or trying to address the issue with the gummies. We also have the issue on the street, and even in some of the dispensaries, there can be a wide range of concentration that's available. Even in a state like Colorado, I'll show you a slide a little bit later on, where they were getting marijuana from dispensaries, there was a wide range. So, one of the things with street marijuana, we do see a really wide range of potency and the different components there. When we're talking about using any drug, and this includes marijuana, we often have to make an issue of benefit versus harm. So there's still this risk assessment. And so a clinician that is going to be prescribing marijuana needs to really assess the benefit versus the risk. And part of that benefit is going into the potential side effects. And one of the big things that I've seen, especially over the last 3 or 4 years, some of this harm situation may come into place with regard to driving issues, maintaining your job, the problematic issue of failing a drug test. The other thing that complicates things is each state is developing their own laws and their own legal restrictions, and those can differ from federal. So, one of the things we're running into and have run into since the very early beginning is a prescription in one state may not be recognized in another state. So these are all issues that have created a lot of problems when you opt to potentially use marijuana. The other thing that's happened is so marijuana, the legal thing sort of took a back seat, and we saw the other cannabinoids move to the front. And you're going to see me talk about this several ways. We have what is referred to at one time the CBD wave. And CBD is cannabidiol. So we'll refer to that as CBD. This is considered the safe marijuana, the safe cannabinoid, if you will. But here's the problem: a lot of CBD is in over the counter products. There is estimated, this is an old estimate. I would say that it probably exceeds this now, but it's been estimated that there's clearly over at least 1,000 CBD products that are being sold through internet, dispensaries, pharmacies, retail stores. I mean, one of my students failed a drug test because they got CBD that came from Tractor Supply. I've seen some of the individuals are buying it for their pets and using it too from pet stores. Been a lot of media coverage. And the other thing with marijuana and the cannabinoids in general is there's this perception that this can be used to treat everything and that it's a natural product and it's very safe. In fact, one of the things that I've had some people that are really pushing strong for legalization of marijuana cite things that there are more side effects associated with taking a common aspirin than you get with marijuana. That's misinformation. Okay. Big business, a lot of companies are moving offshore. It's probably exceeds a $60 billion market value. So it's very lucrative. And that's one of the things that has pushed CBD and marijuana, and a lot of times they sort of get mixed by referred to as cannabinoids. One of the things that we found is when CBD and the cannabinoids and medical marijuana or marijuana came up, is one of the things that's been sort of a barrier has been it's a Schedule One in many states. Federal government classifies it as a Schedule One drug. And I know as a scientist, when we're doing studies in Schedule One drugs, we have a lot more barriers and things, regulations that we have to follow, which makes it more difficult to work with. It's not that it can't be overcome, but basically, it makes it more difficult. The other thing is what we're seeing on the street may differ between what we get from the National Institute of Drug Abuse, NIDA. When we first started a few years ago, when we looked at CBD alone, cannabidiol, there was only 21 published studies that came out, and this stuff has been around for a long time. And the other thing is, if you look at the literature associated with the effects of marijuana, a lot of times we didn't know exactly how much of the other cannabinoids were there. But nevertheless, what we've seen is, especially CBD, has been sort of this cannabinoid that's moved in because it's more legal and people have started using it. And so a lot of people who are not getting medical marijuana may start using CBD. And when you look at it, one of the things you see looking on social media, the internet, and so forth, and even in the literature, one of the things that's coming out about not only marijuana, but CBD is that the states are even listing this is approved for these certain diseases, and some of the data for these particular diseases is really, really weak. For example, if you look at the conditions that it has been cited to treat or advocated for treatment: anxiety, cannabis use disorder, Crohn's disease, diabetes, epilepsy, Huntington disease, Parkinsonism, opioid use disorder, schizophrenia and psychosis, autism, cancer, sleep disorders, pain. So there are some studies that suggest that the cannabinoids may have a benefit. There's a lot of work that's being done looking at the different individual cannabinoids and maybe trying to tease it out. But with many herbal type preparations, which we would consider marijuana sort of an herb, there's a mixture. There's a mixture of components that are there. And so you may or may not know what you're getting. And so trying to get pure CBD, and some of the studies have used a commercially available CBD, which may not be completely pure, has created a lot of problems in trying to sort this out. So if we look at sort of a broad spectrum, and this is not everything, if you look at the cannabinoids, your body makes endocannabinoids. One of the reasons people cite that marijuana is safe is your body makes them. Okay, they're actually derived from from a substance many of you may be familiar with, arachidonic acid. Arachidonic acid is a precursor to a number of substances, including prostaglandins and so forth. And the endocannabinoids are considered sort of an endogenous modulator, and interacts with a number of transmitters and modulates those. So there is no wonder that some of the pharmacological and toxicological effects that we're seeing would be associated with this. The phytocannabinoids, these are the ones that we have the most publicity about, most people are familiar with. The phytocannabinoids, there are a number of naturally occurring compounds in cannabis sativa, okay? And there's various different forms of cannabis. In fact, here in the Southeast, several years ago, there was a botanist that made a lot of money going around when people had been arrested for having cannabis. He would go and say it was a different form of cannabis that didn't have the psychogenic properties. But the phytocannabinoids include THC, cannabinol, and cannabidiol. And then the last one here that I got listed are the synthetic cannabinoids. Okay, these are produced, actually, they're congeners of either THC or cannabidiol. One of our legal prescriptions that we have, it's called Marinol, is actually a synthetic cannabinoids. But we also see some of these synthetic cannabinoids are made by clandestine labs and can be pretty nasty. And in fact, one of the things that we have seen is in certain states where that marijuana was legalized or medical marijuana was legalized, people have taken synthetic cannabinoids, and their concept is sort of like, well, it's a cannabinoid. It was just made in the lab rather than the plant. And some of these synthetic cannabinoids have some pretty toxic effects. For example, in Colorado, we saw an increase in ER admissions with the use of synthetic cannabinoids once marijuana had been legalized for medical purposes. So, just as a quick review, the THC, we usually refer to this as THC Delta-9. It is sort of the main component in marijuana. Okay. It produces the psychoactive effects. It is responsible for the euphoria. I've got increased reaction time, meaning that it takes you longer to respond. People have loss of memory, may have cognitive functioning episodes, it is usually cleared from your blood pretty quick. Now, it varies a lot, so we've got mixed information, but the half life from your blood is roughly about 30 minutes, but it can be longer and it can be detectable in blood and urine. Okay, so if we see Delta-9 THC, that is a concern and usually means the individual has taken marijuana, okay, and has the psychogenic. Now, you will hear me talk about Delta-8 and Delta-10 THC, which has created another problem, which we'll address very shortly. CBN is cannabinol. Cannabinol is a very good interest to drug companies. It's been shown to be an analgesic, so it relieves pain, helps people sleep. Actually, there's some studies in vitro showing that it can promote healing, that bone cells are grown. It has some antibacterial properties, maybe anti-inflammatory, can be an appetite stimulant. So there's a lot that pharmaceutical companies are interested in with cannabinol. You can think of several instances with how this works, how it could be a pharmaceutical. And then we have CBD, which is really the one that has come on strong. And the thing about CBD is that it can actually modify the effects of the Delta 9 THC. One of the things it can do is THC gets broken down in the body by the cytochrome P450 system, and it gets broken down to 11 hydroxy THC. And 11 hydroxy THC is an active metabolite of THC. We don't get CBD forming from THC because it doesn't formed by the heat from smoking or by metabolism. But the thing about CBD is that it actually may have it may antagonize some of the effects of THC, which may be good. And in fact, a lot of states, their laws are saying that medical marijuana should be about 50-50. In other words, you should have about 50% CBD and 50% Delta 9. And the reason for that is the CBD will mitigate some of the side effects of the THC. And then this other one I've just mentioned is because it shows up on drug tests a lot, is the tetrahydrocannabinol carboxy metabolite. This is the metabolite that stays around in the body's fat. A lot of times when people get tested for marijuana, it will pick up the THC carboxyl in urine or in blood and even hair, and it will stay around for a while. So, if someone tests positive on a drug test, the first thing we want to know is did the drug test detect THC carboxyl, or did it detect Delta 9 or one of the other cannabinoids? Many times, the screening tests that you see in hospitals and employment will primarily pick up the THC. And basically, you can't relate a THC carboxyl level back to level of impairment, but it does indicate that someone has been exposed or ingested marijuana. Now, the other thing there has been significant research done is we do know there are cannabinol receptors. Okay. As a pharmacologist, we often look to see where the receptors are. If the receptors are there, that gives us an idea that the drug can act there. So you see on this slide here, we find that there is receptors in the cerebellum, and this would explain cannabinoids' effect on movement in the basal ganglia, another area involved with movement. The cerebral cortex, that would explain some of the effects on cognition. The hypothalamus, that explains the effects of appetite, the munchies. The hippocampus is going to describe or basically explain why we see that marijuana may affect learning, memory, or the stress reaction. In the medullary area, there is nausea and vomiting in the chemoreceptor zone, which most of you are aware of. A big push for getting marijuana legalized was to use it as an antiemetic, especially for cancer patients. And we also see that there's CB receptors in the spinal cord. And this has been an area that a lot of drug companies have been interested in because the idea this may be a site of action where drugs could potentially be beneficial for spastic disorders and potentially pain. As you can see, these different receptors in the frontal cortex, basal ganglia, hippocampus, and the central nervous, all these sites, pleasure, movement, learning, memory, pain. We also see that the CB receptors are in the mesolimbic reward center. This would explain the reinforced pleasurable activities. It would explain the addiction potential for these drugs. In the cerebellum and basal ganglia, as I just said, the negative aspects of this is it will account for the person having problems with coordination, being extremely clumsy, having difficulty, and that's especially for recreational users. But from a positive standpoint, these receptors in the cerebellum and basal ganglia may be very important, and marijuana or cannabinoids may be important for treating the spasticity, especially in these upper motor neuron diseases such as multiple sclerosis. So again, like most drugs, there's a good and bad, sort of a Dr. Hyde situation that we've got dealing with it. Okay. Hippocampus modulate mood. We do see people's mood can go up and down. Now, most people, their perception is marijuana is going to put them in a good mood, a very chill mood. It's not everybody. So this mood can go either way. Most people are thinking it's going to chill people out, but sometimes we can have just the opposite effect. A big concern we have is whether this is medical or recreational is what's happening with the prefrontal cortex and the hippocampus because we're concerned about it influencing or affecting a person's concentration, their short term memory, their ability to maintain attention, their tracking behavior, especially when you're looking at someone driving or doing some sort of work that requires them to follow things. And then the hypothalamus, interestingly, most people are familiar with marijuana producing the munchies. We've actually seen that that is one of the things that we've used marijuana for is in these wasting diseases by stimulating appetite, that can sometimes help quite a bit. And then again, in the spinal cord, the real concern and real interest there is how these may modulate central pain pathways and be a good analgesic. A lot of people are thinking, all right, marijuana or these cannabinoids may be a better alternative than opioids or can be used to reduce the amount of opioids. So that's one of the big things that's being considered. This dopaminergic pathway, as I mentioned earlier, one of the things that we find is a lot of people believe that you can't get addicted to marijuana. Part of that is, I think, some PR to promote the approval of marijuana. Another of it sometimes is people may use it occasionally, and so not may not be using it on a regular basis. So the idea is that people can't abuse it. And the other thing is sometimes we see marijuana when somebody checks in for abuse or substance abuse issue, marijuana is one of many drugs, and most people are focusing on the other drugs and not really thinking of marijuana being the substance that's really abused. But we do see there's a significant number of people that actually check into substance abuse programs specifically for marijuana alone. So we do know there is an abuse and dependence potential with marijuana. Now, this last statement I have on this slide is interesting because many people make the case that no one has ever died as a result of marijuana overdose. Okay. And that's why I have this statement no known lethal overdose. Okay. And a lot of that is because it is believed marijuana has very minimal effects on the autonomic nervous system, that there are very few receptors in the brainstem. I will tell you that we now have one reported incidents of marijuana overdose. It was published in the New England Journal of Medicine. And granted, it was a person used huge amounts of marijuana, but we do have a documented overdose due to that. So again, if you say it's never going to do it, there's always someone that's going to show you differently. Now, another thing that creates problems is when we look at the various cannabinoids that are present. One of the things I always tell people is that when you're growing plants and you're looking at compounds, and I've done a number of bench studies on different compounds and herbal medicines and things like that. One of the things that's going to occur is when you're growing a plant, the actual concentration of the different constituents is going to vary based upon the growing conditions. The example I use, I'm sitting here in my office at my house and I'm looking out at our small garden is, and I love growing peppers. I should say my wife grows those and I love eating the peppers, but jalapenos. So if I take and I really, really water the jalapeno peppers a lot, I mean, just a lot, the pepper will grow and it'll be a very mild pepper. Okay. However, if it's a drought and I'm not watering as much, the pepper still grows, but it gets really concentrated. So, depending on my growing condition, the amount of capsaicin, which is the heat forming component in peppers, can vary. Same thing with marijuana. But in the raw plant, we have THC-A and we have CBD. These are acids and CBC, and some of those may have their own actions with themselves. But when they get heated, they get converted to THC and CBD and CBC and CBG. And then even when the marijuana gets aged, we see some different changes. And one of the things we found is, and I'll point this out shortly, is Delta-8 THC. In some of the plants, we don't have a lot of Delta-8, but in what's being sold over the counter, quote, legally, is been reinforced with a lot of Delta-8. And so the nature of the marijuana can differ not only in the amount, but also in the specific constituents that's there. So that's a very important thing, especially if you're prescribing. The question really becomes, what am I prescribing? Cannabinoids are not new in our medical situation. We have some that are medically available. The one we've had around for a long time is Marinol, which is dronabinol. We also have Nabilone. And fairly recently, we had the release of Epidiolex, which is a CBD. Canada's had nabiximol, and Europe had one called Rimonabant. That one was actually tried to get approved in the United States, but was not approved by the FDA because of the concerns of depression and suicide in some of the clinical trials. So if you look at dronabinol, and this is what I tell my students all the time. If marijuana was as good as everybody says it is, I mean, we've had Marinol around since '85. To my knowledge, it's never been a top 300 drug. Okay. It's a Schedule 3. It's actually a synthetic form of THC, and it was approved for use for nausea and vomiting that occurred during chemotherapy. It also has been approved for treating AIDS because of the anorexia and the wasting. So the Marinol actually will stimulate the appetite. Nabilone was another synthetic one, same indication as dronabinol. What you really see between these two is really a little difference between onset and duration. So dronabinol kicks in over 30 to 60 minutes, last up to 6 hours. Nabilone kicks in 60 to 90 minutes, last up to 12 hours. As far as therapeutically as an antiemetic, it's about the same and actually pretty close to what we saw with some other drugs we used for treating nausea, the phenothiazines. What we did see is that when a person started with these drugs, that especially in a naive person, we had to be careful because they would experience the euphoria or dysphoria, cognitive clouding, drowsiness, and dizziness. And then as they used it more and more, then they would sort of develop a tolerance to that. So when a person was first starting it, this was more of a problematic issue. What we found with these two drugs, which created some problems, with them as far as drugs, is again, they went through first pass effect, so they're metabolized fairly quickly. Different levels of absorption that vary between individual. So the blood levels are somewhat unpredictable. But we had a new drug that moved into the market, and that's ondansetron, which was originally marketed as Zofran. And these act on the serotonin receptor. They're actually serotonin receptor antagonists. And these actually are much more potent. They're more predictable, don't produce the psychotropic effects that we see with dronabinol or nabilone, and we could give them IV because previously we did not have a way to give IV dronabinol or nabilone. What we found was these drugs, dronabinol and nabilone, moved to the second and third round. They were hardly ever used as a first line agent. And what we used them is if the other drugs didn't work, then we would try it. So again, this concept that marijuana is going to treat all of these things better than what we have has just not panned out like people have said it would be. Now, I mentioned cannabidiol earlier, and this is sometimes referred to as the other cannabinoid that is present in botanical preparations. So it's the phyto cannabinoid. The big thing about CBD is that it's not psychoactive, okay? But in fact, it may actually mitigate anxiety and paranoia that can be caused by THC. Now, that's something I found out. A lot of people do not think that THC produces anxiety or paranoia. Their concept is, because all the media and everybody that talks about it, is you smoke some weed and you sort of chill out. Okay. But what we found is that this may mitigate it and may actually work synergistically in a positive manner with THC. CBD may actually be anxiolytic and may even have some antipsychotic properties. And in fact, over the counter CBD supplements, they will suggest that these things are calming agents. Keep in mind, a supplement can't say that this is being used to treat anxiety or psychosis, but it can say may reduce stress. But the other thing about CBD, and this resulted in the Epidiolex being approved, is that it had some anticonvulsant and neuroprotective effects and actually was effective in some severe forms of spasticity. So if we look at comparing THC and cannabinol, so when I'm talking about THC, I'm primarily talking about Delta-9. Delta-9 will produce the euphoria, the anxiety, the psychosis, the cognitive impairment, and it'll actually stimulate appetite. CBD doesn't produce the euphoria. Now, maybe in real high doses, we may see some, but it tends to be anti-anxiety, antipsychotic, doesn't produce the cognitive impairment. Again, higher dosages, we may see it. And that's one of the basis for why a lot of states want CBD to be at approximately 50% of the medical marijuana. Now, a couple of things is nabiximol is one that's being looked at. It was approved in Canada. US has tried it in some trials. I don't think this has made it to there, but it's been used for neuropathic pain and cancer pain. But here's what I wanted to point this out, and this is one of the reasons I put nabiximols in here. So it's actually available in Canada as a oral spray, and notice the concentration. It has 2.7 milligrams of delta-9 THC and 2.5 milligrams of CBD. So it's about 50-50. It kicks in pretty quick, doesn't produce the sedation, doesn't produce the memory impairment. And the other thing which is impressive is when you look at the peak concentrations, they're about 20 times lower than someone would get if they were smoking marijuana. And the idea is the lower THC levels would reduce the potential for dependence. So this is part of the research that has promoted the addition of CBD in with THC. I've mentioned Epidiolex, and the interesting thing about Epidiolex is that it's actually a purified form of CBD that was derived from plants. Okay. This was actually the first FDA plant derived CBD product. It's approved, its indications are very, very slim. It's indicated for severe forms of epilepsy. It was originally approved as a Schedule 1, but as most of you know, a C1 or a Schedule 1 drug has no medical use. So you can't approve a drug to use medically and still call it a C1. But what happens is they classified it or reclassified it to a Schedule 5. Now, interesting with Epidiolex, the FDA approved warning lists a possible positive drug test. So that is a concern. And it specifically advises the clinician to advise the patient that you may potentially test positive for a cannabis drug test. And that would be important. Now, the people that this was approved for, usually the type of epilepsy and seizures that they have is not going to be a person that is going to typically drive. I met with one of the reps and she said, well, we don't really worry about it because most of these people are too sick to drive. So we don't have to worry about the drug testing, but they still need to be tested or be aware of that. Now, here's an interesting thing. Some of you may have heard of 2018 Farm Bill. So as we were trying to get more research on marijuana, one of the things was happening was who grows it. In fact, right now in the United States, as far as who is able to grow marijuana, if I ordered some marijuana to do research from the National Institute of Drug Abuse, the University of Mississippi has got the contract to grow marijuana. Okay. The question is the marijuana that they grow in their fields under well controlled growing conditions, that may be different than what we see on the streets. Okay. Just with constituents and other things. But anyway, what they did was to try to get like CBD and things like that. They passed this farm bill in 2018, which excluded hemp and derivatives of hemp from a Schedule 1 listing, okay, which allowed farmers to produce industrial hemp. And as a result of that, that was a pretty good product and cash crop. And it ended up developing a surplus of hemp. Now, the other thing is that in order to meet this Farm Bill's regulations, the cannabis plants had to contain less than 0.3% Delta-9 THC. And if that's the case, then their products were no longer scheduled products. And that included CBD, Delta-8, and Delta-10 THC, and also another one, tetrahydrocannabinol O-acetate. We've talked about CBD, and I've mentioned briefly Delta-8 and Delta-10. So keep that in mind. Now let's move to CBD products move back there a little bit. There was a recent article in the Journal of American Medical Association. And one of the things is we had a lot of people that started using CBD. It was sort of like the non-marijuana marijuana. This JAMA article, what they did was they actually went online and they purchased 84 CBD products from 31 different distributors. So a good cross section there. So, and then they analyzed them. And what they found was 70% of the products, the level of CBD differed from what was on the label. So, in other words, what they were advertising was the amount of CBD, that wasn't the amount there. Half of those products, there were more CBD than indicated. Quarter of the products had less CBD. So again, you don't know what you're really buying. It has CBD in it, but you don't know how much. And that's sort of like, somebody giving you a prescription going, so here's some Lexapro. I'm not sure really how much is in it, but let's see if it works. The thing that was scary is in 18 of the samples, there was actually Delta-9 marijuana, Delta-9 THC. There was a concern with the Epidiolex about off-label use of that prescription drug. But I will tell you that, that drug is around $3,000 a month. And a lot of times they felt like that's going to be more than someone would pay for. That's just what the drug reps had told me. So how safe is CBD? I mean, it's an over-the-counter product and you can buy it legally. My biggest concern with a lot of this is literally the situation of how much are you getting? Actually, what am I getting and how much am I getting? Our clinical data, they don't do clinical studies on supplements. Okay. Very few studies on supplements. It's one of the things we're doing. So a lot of our data actually came from Epidiolex, which when it went through its things, but the Epidiolex was a highly purified and very well identified subject there. What we did see in the clinical trials with Epidiolex was basically we saw some liver enzymes go up. We saw the metabolism went through 3A4. We did see at high doses there may be an increased risk of sedation or drowsiness, especially when combined with other CNS depressants. But we still have a lot of concerns with regard to this. Now, I mentioned Delta-8 earlier. So Delta-8 typically in the legal hemp plants that can be grown according to the 2018 bill, those 2018 products, basically what we find is that there's very, very, very low levels of Delta-8 in it. So Delta-8 can actually be synthesized from CBD. So we actually, because of the 2018 Farm Bill, what we ended up getting was we got a lot of CBD, which then was being converted to Delta-8. And then what was happening were manufacturers were taking the Delta-8 and adding it back to edibles and other products, inhalation that people would vape and things like that. So what we found was the plant material that had low Delta-8 and Delta-9 THC were actually being laced with synthetic Delta-8. And that was a big concern. And the reason it was a concern is because when you look at Delta-8, it has some psychogenic properties. And in fact, the FDA actually put out a warning that said Delta-8 products have not been evaluated or approved by the FDA. The FDA considered them supplements, and they had concern over the variability in the product formulations. And they're saying these may be marketed as hemp products. There were adverse events that were reported and the Delta-8 has psychoactive properties that are similar to Delta-9. And we also saw that the synthesis of the Delta-8 introduced toxic chemicals into those products. What we found is the Delta-8 is less potent and has a shorter duration of action than Delta-9, sort of a dose related. But what's happening is they're putting a lot of Delta-8 into some of these products. And so even though it's less potent and doesn't last as long, when you elevate the amount into these products, edibles and things like that, it can be very significant. And in fact, I'm seeing more and more with drug tests and driving and things like that, that the crime labs are breaking it down. And I'm seeing people that have taken gummies and they have Delta-8, Delta-9, and Delta-10 all in there. There's also another component that gets added in here, gets produced, and that's the tetrahydrocannabinol, which is actually more potent than Delta-9. And when it gets heated, it actually releases a very toxic catein gas. With every drug, all of them will have contraindications. Okay. And when you look at the products that are out there, the recommendation is that there are certain conditions that a lot of the medical marijuanas are putting as contraindications. In other words, they assess that the risk over or outweigh the benefits. And of course, with every drug, hypersensitivity is one. But there are also, most states are including it's contraindicated under the age of 25. There's a history of psychosis or schizophrenia. If there's a past history of cannabis use disorder or an active substance use disorder, they even list significant cardiovascular pulmonary disease. And also, it's contraindicated in women that are pregnant or breastfeeding because that can cross the placenta and can also cross through the mother's milk. Now, we gained a lot of information when Colorado legalized marijuana. And one of the things is they started looking back at that. Someone did an analysis in 2015. So a lab basically went to certified growers and sellers, got 600 samples of bud, and what they found was that the average THC level, we're talking Delta 9 level, was about 18.7%. But in some retails, we actually saw that the THC was greater than 30%. So a big variation. We also saw that there was little or no cannabinol, CBD, averaged only about 0.1%. Remember, a lot of states want about 50-50. So we saw a lot of variations, and these were from the government approved dispensaries. The other issue that comes into play when we look at recreational versus medical use, there's a different way that you use it. The safest way that people will usually say, or easiest way to administer marijuana, is by smoking it. That is difficult. If any of y'all dealt with people with inhalers, we have to often teach people how to use inhalers properly. So if someone was smoking, we have to frequently make sure they know how to smoke. Now, the edibles have come into a new, easy way of doing it, but it's created its own problems. But the other thing is in recreational marijuana, what you buy off the street, a lot of different impurities. There's been plenty of studies demonstrating all of the impurities. And not only are the impurities being demonstrated, but we find that they can produce pulmonary lung cancer and things like that, just like cigarettes did. So when we are using these plants, a big concern we have is the dose can vary due to the concentration of the plant. Look at what we saw in Colorado. The ratio of THC and CBD varies. This can vary according to geographic region where it comes from. Some people have said, well, to get around this, let's adopt a central source of cannabis. Nobody's is agreeing to that. We also, when this comes in, there has to be adequate monitoring and prevention of addiction. Those programs have to be put into place. And we are just now getting results of has there been an increase, a decrease in drug use and so forth. So we're just now going through that data. Some of the stuff that's come out now is very early on, and we need a little bit longer time. We also see with cannabis, there's always the possibility of contaminants. We find various bacteria and fungi, heavy metals. On the street, people sell it by the bag, and people will put glass beads and sand in the street cannabis to increase the weight, which can, create a problem by causing damage to the lungs when you inhale those things. We know these THC and these other components actually will affect neurotransmitters, and we know there's data in vitro that show that it can affect cell growth. We know that they're fat loving compounds, they're lipophilic compounds, so they can stay in the body for weeks, especially when people are smoking a lot. We know that even in maternal tissues, some of the studies in dogs is the maternal tissues actually served as reservoirs. So the drug accumulated in there and then was slowly released. And we know it crosses the placenta. So there is big concerns with regard to medical marijuana and marijuana use in general. We know today what's on the street, significant increase from what we saw back in the 70s. It's estimated that we're probably looking at up to a 25-fold difference in concentration. I just read an article where pregnant women are smoking or vaping more marijuana and actually drinking more than what we used to do. And THC and these cannabinoids can interfere with folic acid, can affect the fetus that way. And we've seen some mouse studies that have demonstrated that this can create problems with fetal development. In Colorado, this I mentioned earlier today, is that we saw once marijuana was legalized, we saw increased hospitalizations. Patients showed up in the ER and they were hallucinating severely, didn't have a gag reflex, had difficulty breathing. And these were synthetic THC, which were the products that they were using were called Botanical Sachet, Sexy Monkey, and Crazy Monkey. And these were actually, promoted as being safe marijuana. We do know marijuana addiction occurs. We do know that it's estimated about a third of the people who use marijuana may actually have marijuana use disorder. If they start using marijuana before the age of 18, they're somewhere between 4 to 7 times more likely to develop MUD, marijuana use disorder, or the cannabis use disorder, the terms that's used. The withdrawal symptoms are very similar to a lot of other things. They're irritable, mood problems, sleep difficulties, appetite goes down. They have the cravings, the restlessness. The symptoms usually peak first week after last dose and typically last about 2 weeks. One of the things that there's been studies is when people have developed this, and in the animal studies, we do see that there is a reduction in the production and sensitivity of endocannabinoid receptors. So there's some downregulation. And again, the studies are showing there's significant amounts. In 2015, it was estimated 4 million people in the US met the criteria for MUD. 138,000 voluntarily seek treatment. That was for marijuana use disorder alone, not with other drugs. This is a symptom that showed up that many people have not heard of before. It's called scromiting. And the scromiting term comes from the term of a combination of screaming and vomiting. So heavy marijuana use typically is we're looking at multiple times a week for longer than a year, puts them at a higher risk. And what happens is this produces a hyperemesis, so they're throwing up and it's extremely painful. So what happens is they scream, and that's where the term scromiting comes from. So it's dose related. When the marijuana use stops, it goes away. What we looked at again is in the 90s, we're looking at per joint 1 to 3 milligrams of THC. Currently, we're about 18 milligrams per joint. CBD doesn't appear to cause this, but this has gained some publicity over the last few years. It's interesting and ironic that marijuana is often promoted as a antiemetic. Does marijuana affect your brain? These are some SPEC scans. I always like showing these to the students. So on your right is a normal brain, and on your left is a 16-year-old that has been using marijuana for 2 years. Those are not physical holes. Those are areas of decreased function. So pretty significant effects there. Another one, this one, you got an 18-year-old using 4 times a week, 3-year history. And then you can see various other ones, scans that are showing this over a period of time. So with younger patients and students, I found that SPEC scans are good. Now, getting back to, there was a question, are prescribers actually prepared? They surveyed medical school deans, residents, looked at medical school curriculum back in 2017. They found 75% of the medical school deans said their graduates were not all prepared or only slightly prepared to answer questions about medical marijuana. And yet this is being promoted. 94% of the medical school deans reported graduates are not at all prepared or slightly prepared to prescribe marijuana. And that's what I've seen specifically in giving programs to physicians. When you look as do these things really work? In 2017, the National Academy of Science and Engineering Medicine issued a report and stated there is a conclusive or substantial evidence for medical marijuana being effective for chronic pain, for chemotherapy-induced nausea and vomiting, and for spasticity associated with MS. Their statements said the benefits must be balanced with the risk, and we've talked about those previously. In another article by JAMA, they make the statement, insufficient evidence exists for the use of medical cannabis for which its use is advocated. Despite the lack of evidence, various state governments have recommended cannabis for the management of more than 50 medical conditions. Cannabis is useful for some conditions, but patients who might benefit may not get appropriate treatment because of sufficient awareness regarding the evidence supporting its use or confusion from federal law. So there's real concerns, and there is a lot. This is sort of the pseudoscience of where individuals are basically saying that it's not as good as what a lot of people are concerned with. When we're dealing with elderly, we have to be careful for falls, especially if they're using any other CNS drug or any blood pressure medications. We don't really have a control over what the patient is getting in dispensaries. And a lot of times patients actually don't know how much THC or CBD that they actually are on. And these are important things for us to know. Now, I picked a few slides dealing from what we saw in Alabama, but the requirements in Alabama is prescribers have to pass an exam. They have to verify the patient has a qualifying condition and conventional therapy or medical treatment has failed. And then this is a list of the qualifying conditions that it can be used for. So I won't read through those, but you've got them there in front of you. Patient has to show proof of Alabama residency. They have to have a medical marijuana card. That's going to cost about $65, and they have to enter into a statewide cannabis registry. If they're a minor, under 19-year-old, goes through the same process. They have to have a designated caregiver, and both caregiver and the minor must be Alabama residents and registered. So a lot of red tape to go through it. They recognize recreational marijuana is a significant threat, and there's significant penalties. Basically, they limit the possession of 70 doses, daily doses, even if you've got a medical marijuana license, and jail is the consequence. This can be prescribed for up to 12 months. The dosage has to be 50 milligrams or lower, but after it's determined that it's not working or the patient is terminally ill, they can increase it to 75 milligrams. And when they go above 75, then the patient's driver's license has to be suspended. They have specific forms that are available. And one of the things, a concern about the edibles, they're non-sugar coated gelatinous cube, cuboid, or lozenge. And actually, I think the state has only one flavor of which it can be dispensed in. They do not allow it to be smoked or vaped, cannot be sugar coated, cannot put in food, cannot be consumed or sold as a raw plant. And right now, I think Alabama was looking at peach being the official flavor. So here's a big issue we run into, that I've run into some law cases that this has come in about. If you're on an anti-anxiety med like Xanax, your employer will typically let you work. But the marijuana laws in several states basically do not require the employer to let you work if you're using medical marijuana. They can basically refuse to hire you or they can fire you. And they may actually create a drug testing policy against medical marijuana. So they require employees to notify them if they start using the drug. Employers aren't required to pay for the drug through medical insurance, and they can deny workers' comp. That's one of the big things that I've seen that has popped up with medical marijuana. Can't sue the employer. If fired, they could be considered having been discharged from job because of misconduct. So it can create some big issues. In Alabama, I think what's interesting is they have not created the registry. They have not established dispensary. So even though it's legal, there's no way for them to actually get it. As I mentioned before, there are some studies that have suggested that people taking commercially available CBD or hemp seed oil can actually test positive in the workplace drug test. So that can be a big issue that may have to be addressed. So, sort of getting here toward the end, because I'm running out of time, I've actually gone over. Cannabinoids do have medical value, okay? They are not necessarily superior to existing medications. They don't cure everything. They are natural substances, but they do have side effects, just like everything else. And many of the cannabinoids have very similar effects. There's some differences, but there may be some different effects there. Medical cannabis obtained from state approved sources is required to have consistent amounts of cannabinoids. Theoretically, yes, but we've already seen that that may not necessarily be the case. Patients aren't protected if they have a marijuana card, and the clinician, unless they meet the criteria for the state, can't just write them a prescription for cannabis. So these are things that we're coming across with. And then my last slide here is basically in 2019, we had a 52-year-old man who basically used liquid marijuana at home 10 to 20 times the dose and ended up dying. So we have had a death due to marijuana. I appreciate your attention. We may have a moment or so, Phil, for a couple of quick questions.
Oh, I do have questions in the Q&A. How to distinguish the quality of CBD and how to trust licensed dispensaries.
Okay, so the quality of CBD, that is a big concern right now, because other than the Epidiolex, we don't have anything. All of these are supplements. So you're really left up to what the supplement company basically says it is. Other than that, sometimes when I have a case that somebody's taken the CBD, what I've done is ask them if they want to analyze it. But right now, the FDA will, if they find out there's a difference, the FDA may pull it out, but it's more reaction and it's not, they're not required to demonstrate purity with regard to that.
I want to express my deep thanks to you, doctor, for being here and for offering something that obviously is of such high interest to so many people. And thanks to the program here in clinical psychopharmacology that allows people that have a doctorate in clinical psych, either PsyD or PhD, if your state allows for prescriptive privileges, it certainly is a way to move towards that. But even if you don't live in that state, as Dr. Tackett talked about, it's important for people to understand about the medications and the substances that people are taking. So thank you so much, Dr. Tackett. Thank you all for being here, and thank you for caring so much about psychopharmacology and prescriptive rights.
I did see one last question up here. The impact of women use on CBD THC from street licensed dispensaries. That is a question with regard to the reproductive health has really not been addressed really well. Our biggest concern with regard to reproductive health, we do know marijuana itself can affect the tissues. We know that it can affect sperm. We know that it potentially can interrupt some endocrine issues depending on the dose. And I would say that a lot of people, the edibles people are getting, and again, a lot of patients don't think anything of it since they purchased it from a legitimate source. But there is such a high variability. What I have seen is people in the healthcare industry, people in education, and people in law enforcement are at the highest risk for potentially failing a drug test. I see a lot of nurses, for example, use CBD products to help them sleep, and they say it's helpful for their stress. And I've warned several of them, and I've had a couple of my students that have failed drug tests in the hospital systems, and the hospitals basically are telling them they're not gonna work in a hospital anymore. And one of my students in particular that had been using the CBD product, he was bipolar, and said it was really very calming for him, and he was using it on the weekends. He failed his drug test. We don't know if the CBD product happened to have THC in it or what. Nevertheless, is that the hospital system, we had to move him out, and he wanted to work in that hospital system, and that is not going to be possible. Some of these hospital systems have said carte blanche. No, I've found that with education system too. So it is a concern. And one of the things I've been trying to tell people, clinician, if you're prescribing, your patients need to be aware of that. And if you are dealing with a patient, sometimes they haven't been told that, and it's wise. And I have found that sometimes patients are reluctant to tell you that they are taking a CBD or a THC product, but it is very important for us to know so we can inform them. With that, I thank again all of you. I hope you have a wonderful night. Thank you again for attending.